Hello everyone, welcome back to the hepatopathology course. In this particular lecture, we'll be discussing about the mechanism of various liver injuries. So before we move on to the different liver injuries, let us first understand the blood supply to the liver. Liver is the largest internal organ of the body and it is supplied by two major vessels. One is the portal vein, which supplies 75% of the blood to the liver, and this particular blood is basically derived from spleen, pancreas, intestine and stomach, and it is bringing the nutrient rich blood to the liver. Now this blood which is coming through the portal vein is relatively oxygen poor. The second vessel which supplies the liver is the hepatic artery, which supplies around 25% of the blood to the liver. It is derived from the celiac trunk and it is basically supplying predominant oxygenated blood to the liver. So that is how the blood supply of the liver is like. So inflow is through hepatic artery which supplies 25% and portal vein which supplies 75%. Now the outflow from the liver occurs through three major hepatic veins. These are the middle, right and left hepatic veins, and they drains into the inferior vena cava. Now the blood which is entering into the liver through the portal vein and hepatic artery, it goes into the sinusoids, and from the sinusoids it enters into the central vein, and from the central vein into sublobular veins, and thereafter it is released into the hepatic vein, which then goes into the inferior vena cava and finally back to the heart. So that is the inflow and outflow of the liver. Now another important function of the liver is the formation of the bile. Now this bile is produced by the hepatocytes and it is released into the canaliculi, then into the bile duct, and then it goes into the gallbladder. Now if we take a cross section of the liver, so if we cut livers transversely, it is going to look like this on a histological section of a microscope. Now this is the histological section of the liver, and if you see, the central structure is a central vein, and these are the cords of the hepatocytes which are arranged from the central vein towards the portal triad. Now these cords of hepatocytes are separated by these whitish structure. These are the sinusoids. So each cord of the hepatocyte is surrounded by sinusoids, and this structure which arises in the center is the central vein of the liver. It is called central vein because it is present in the center of the lobule. And at the periphery we have the triad of three vessels which are hepatic artery, bile duct and the portal vein. So these three things constitute the portal triad. So that is how the liver histology is going to look like. So if we draw a line from joining all the portal tracts here, one portal tract to the other, we saw a hexagon type of a structure. So when the Kirnan, he was the first scientist who described the liver classical lobule, so he joined the portal tract, he called it a hexagonal lobule because of the structure with which it looks like. So this is called the classical lobule of the liver, and it was first described by Kirnan. Now he said that it is hexagon because it is a hexagonal structure. Then we have the blood flow which comes from the portal tract towards the central vein, and this is the bile which flows from the central vein towards the portal tract. So the direction of flow of blood and that of bile is opposite to each other. Then this is the hexagonal lobule and it is the anatomical unit of the liver. If we talk of the functional unit of the liver, that is the liver acinus. And this liver acinus is different from the hexagon as it is composed of two central vein and two portal triad. So if we join the central vein to the portal triad and then to the central vein, we get a diamond shaped structure, and this is what the acinus is. And this is the functional unit of the blood of the liver. The blood flows from the tract towards the central vein, whereas the bile flows in the opposite direction. So if we see the flow of the blood, we can divide the liver acinus into three particular zones depending on the oxygenation of the different zones. So zone 1 is the zone which is nearest to the portal tract, so it is receiving the maximum amount of oxygenated blood. Zone 2 is the mid-zonal region which receives relatively less amount of oxygen, and zone 3 is least oxygenated and it is seen near to the central vein, that is the perivenular zone. So these are the three zones of the liver, and they are named according to the supply of blood which is coming from the portal tract towards the central vein. So that is the flow of the blood. Now moving on to different patterns of liver injury. So first we'll be talking of the viral hepatitis, that is the hepatitic pattern of injury, and in this viral hepatitis we'll be talking of the hepatotrophic viruses. Now these hepatotrophic viruses, especially the B and C virus, they enters the liver via the blood, and it finally reaches into the liver vessels and then it goes inside the liver cells. So these come through the blood, and once inside the blood they are going to enter into the hepatocytes. So these virus once inside the hepatocytes, they proliferate inside the hepatocyte. So they enlarge within the hepatocyte, they proliferate, and when they proliferate, this particular cell is going to express certain receptors. These receptors are then going to be recognized by the body's immune system. So these are the body's lymphocytes which are there, and they are going to recognize these receptors which are present on the infected cells, and these immune cells are going to come and damage the hepatocytes. So if we see here, the damage to the hepatocytes is occurring basically by the body's immune response and not directly by the virus. So this is different from the damage that we see in rest of the virus. So these hepatocytes are damaged by the body's immune response, and this is what we see on histology. So if we see the histology of viral hepatitis, we see a lot of inflammation in the portal tract, and these cells are predominantly the lymphocyte, the T cells, and these cells are going to damage the hepatocytes which are seen at the interface. So that is how the histology of the viral hepatitis is described by the pathophysiology. So you see a lot of leakage of these lymphocytes from the sinusoids and the capillaries, and they come and enter inside the portal tract, and that is why the damage in the viral hepatitis starts from the interface region, and that is called interface hepatitis, because these lymphocytes are going to breach the tract and they enter into the liver cell plate. The second pattern of injury in the hepatic pattern of injury is the autoimmune hepatitis. Now in autoimmune hepatitis, we have circulating autoantibodies. So these are ANA, asthma, or depending on the type of autoimmune hepatitis, there could be different type of antibodies, and these antibodies, they circulate in the blood along with the blood cells. Now these antibodies, when they find receptors on the hepatocyte, they come and attach to these receptors. So once they attach to these receptors, they are again recognized by the body's immune cells, and these are then going to damage the hepatocytes. Now what is important and different in autoimmune hepatitis from that of viral hepatitis is there is formation of lot of antibodies, which we generally do not see in the viral hepatitis. So these antibodies, as we all know, the antibodies are being produced from the plasma cells. So that is what we see in autoimmune hepatitis. When we see the histology of autoimmune hepatitis, we see the formation of lot of these antibodies, and which are formed mainly from the plasma cells. So the amount of infiltrate that we see in the tract is mainly the plasma cells. So there are lot many plasma cells in the lymphoplasmacytic infiltrate that we see in the portal tract in autoimmune hepatitis, and they are going to produce these antibodies, which are then recognized by the body's T cells and B cells, and they are going to damage the hepatocytes. So again, as we saw in viral hepatitis, the type of injury that occur in autoimmune hepatitis, it starts from the portal tract. The accumulation of lymphocytes and plasma cells occur predominantly in the portal tract, and once they are in the portal tract, they are going to release these antibodies which go and attach to the hepatocytes at the interface. So that is again one reason why we see lot of interface activity in autoimmune hepatitis and lot of plasma cells again in autoimmune hepatitis. So that is the autoimmune nature of injury, where the hepatocytes are being damaged by the lymphocytes, and these are because of autoantibodies circulating in the blood. The next pattern of injury is the steatotic pattern, that is alcoholic steatohepatitis. So when the patient is drinking lot of alcohol, if the patient is taking lot of alcohol, it is going to come to his intestine, and from the intestine through the portal vein, it is going to enter into the liver. So that is how the alcohol is going to gain access into the liver. So once it goes into the portal vein and enters into the liver, this alcohol which he has consumed is going to finally enter into the liver cells, that is the hepatocytes. So this being a metabolite, it is going to metabolize inside the liver cells, and after metabolism, it is metabolized within the cytosol and within the mitochondria of the hepatocyte cells. So these alcohol molecules, they are going to enter in the liver cells, and within the liver cells, they are going to be metabolized within the cytoplasm and the mitochondria of these liver cells, and they are going to generate acetaldehyde. Once this acetaldehyde is formed in the cytoplasm, it goes into the mitochondria, wherein it increases the formation of fatty acid and glycerols. Now these fatty acids and glycerol, they are going to combine together, and they are going to form triglycerides, which could be seen as these yellow fat droplets within the liver cells. Gradually the lipid droplets are going to accumulate, and they increase in size as we see here. So they are small droplets initially, and gradually they are going to be bigger droplets, which are then going to damage the hepatocytes. Now one thing is important here is that in an alcoholic injury we see lot of polymorphs that are generally not seen in the viral and autoimmune hepatitis. So these polymorphs, accumulation of polymorphs, is because of the reasons that in addition to these alcohols, there is certain lipopolysaccharides which are absorbed from the gut, and then they are attached on the surface of the hepatocytes. So these hepatocytes become chemotactic for the polymorphs. So that is why we see lot of polymorphs around the hepatocytes, and this type of injury is called neutrophilic satelitosis. So one is the steatohepatitis, that is damaging the liver cells, and another one is the accumulation of the polymorph that is occurring because of lipopolysaccharide accumulation on the surface of the liver. So when we see liver cell damage because of fat, and then it is called steatohepatitis. The next pattern of injury in the steatosis is the non-alcoholic steatohepatitis, in which the patient doesn't drink alcohol but he has steatohepatitis in the liver. Now in this particular disease, there is metabolic syndrome. Patient is either having metabolic syndrome or he is obese. Both of these conditions are going to cause insulin resistance. Now insulin is a normal hormone which is secreted by the pancreas, and it normally prevents lipolysis from the peripheral adipose tissue. So whatever adipose tissue we have in the periphery, insulin is going to prevent the lipolysis from those fat adipose tissue. In insulin resistance, what happens is there is increased lipolysis in the peripheral adipose tissue, and that is going to be responsible for increased fatty acids in the blood circulation. So there is formation of increased fatty acids which are coming from the peripheral adipose tissue of the body, and then they are going to gain access into the blood. In addition to these increased fatty acids in the blood circulation, the liver itself is producing more fat because the patient is obese, so there is more lipogenesis within the liver. Now the production of fatty acids within the liver, as well as the fatty acids which are getting accumulated from the blood, so these fatty acids are going to enter inside the blood, and this is responsible for high fatty acids accumulation inside the hepatocytes. Now these fatty acids combine with glycerol once inside the liver cells, and they are going to form lipid droplets, and these lipid droplets gradually going to coalesce together and form larger droplets which are seen as lipid droplets or macrovesicular steatosis within the liver cells. Now what is important here is, as we saw in viral and autoimmune hepatitis, the pattern of injury is predominantly starting from the interface. So we see a lot of zone 1 activity in viral hepatitis and autoimmune hepatitis, whereas if we see for NASH or any other alcoholic steatohepatitis, the disease starts from the zone 3. So that is because there are certain enzymes which are involved in lipogenesis which are present predominantly in the zone 3. So if we see for NASH, the disease is predominantly starting from the zone 3 in adults, because there are certain enzymes, especially the beta-catenin pathway, which is expressed predominantly in the zone 3 region. So that is why fat accumulation starts first from the zone 3, and gradually the fat is going to move in the opposite direction, that is in zone 2, and then later on it will involve all the zones of the liver. So that is liver damage in non-alcoholic steatohepatitis, and once the liver cells are damaged, it is called steatohepatitis. The next pattern of injury is primary biliary cirrhosis. So this is biliary pattern of injury where the liver appears green and cholestatic. So what happens in primary biliary cirrhosis? These are the bile ducts, as we already discussed, and they drain the bile into the gallbladder. Now this is the lining of the bile duct. This is lined by the columnar epithelial cell in a normal person. This lining epithelial cells contain an enzyme receptor which is called PDC-E2. Now this particular enzyme is present inside the mitochondria in a normal biliary epithelial cells. However, in cases of stress or any other particular thing, this enzyme is going to be expressed on the surface of these biliary epithelial cells. Now when it is expressed on the surface, there are antibodies, anti-mitochondrial antibodies, which circulate in the blood, and then they are going to come and attach to these PDC-E2 receptors, which has now come to the surface of the biliary epithelial cells. Now once these anti-mitochondrial antibodies attach to this receptor, they are going to damage these biliary epithelial cells, and then what will happen is these small bile ducts will get damaged. So this is what we see here. All the small bile ducts and medium sized bile ducts in all the portal tracts, they get damaged, and because of damage to these bile ducts, the bile cannot flow from the smaller tract to the larger tract, and there will be accumulation of bile within the liver. So that is what we see in primary biliary cirrhosis. There is damage to the smaller ducts and there is granulomatous destruction. The next biliary pathology is primary sclerosing cholangitis. Now, in primary sclerosing cholangitis, the disease predominantly involves the larger bile ducts. Now, what happens in the larger bile duct is there is alternate stricture and dilatation of the bile duct. Because of this stricturing and dilatation, the bile cannot flow from the smaller ducts into the larger duct, and here again there is accumulation of bile within the liver. So, because of this, due to the damage, the bile is going to leak and it is accumulating within the liver cells. Now, as we already mentioned that the leakage of bile or any proliferation of bile duct, it will be accompanied by polymorphs because bile is chemotactic. So if there is any damage to the bile duct in the smaller tract or in the larger tract, that will lead to leakage of bile within the portal tract, and this is going to cause accumulation of polymorphs, which will now come from the peribiliary capillary plexus, and they will now come and get attracted to this bile, and this is accompanied by the polymorphs. So once the liver become cholestatic, it will be green, and gradually the constriction of dilatation of the bile duct, it is going to compress the portal vein, and gradually the liver will show fibrosis and cirrhosis formation, and because of the accumulation of bile, the liver become cholestatic. So in primary sclerosing cholangitis, we see destruction of the ducts because it is predominantly involving the larger ducts, which we do not see generally in our routine biopsies. So what we see in the smaller ducts is that we see a lot of bile ductular proliferation and biliary changes. So there will be accumulation of copper associated protein within the hepatocytes, there will be bile ductular proliferation, and some of the ducts can show onion skin appearance on histology. The next pathology that we see in the liver is the vascular problem. So vascular problem in the liver could be either a problem with the post-hepatic cause, that is the outflow obstruction of the liver, or it could be intrahepatic, where we'll be discussing NCPF and other etiologies, or it could be prehepatic, where it is extrahepatic portal vein obstruction. Now the obstruction to the outflow, that is the blockage to the outflow, if it occurs and involves the major hepatic vein, which could be blocked either by thrombosis or any other cause. Now what will happen once these veins get blocked, the blood cannot flow out of the liver, and if the blood cannot flow out of the liver, it is going to be absorbed, it is going to be retained within the liver, and this will lead to pooling of the blood within the liver. So blood cannot go out through these major veins, and then it is going to be accumulated within the liver. So if we see the histology of outflow obstruction, what we will see here is because of the back pressure, the blood is going to be accumulated in the sinusoids, and once it is accumulated in the sinusoids are going to enlarge, and they are going to compress the surrounding hepatocyte cords. So there will be atrophy of hepatocyte plates in the perivenular region, sinusoids will be dilated and congested. Initially there will be congestion and dilatation, and gradually this congestion is replaced by fibrous tissue formation. So we see venocentric pattern of fibrosis in the outflow tract obstruction. Venocentric means it is going to start from the central vein. So that is what we see in the outflow tract obstruction, where we see the sinuses are dilated and they are filled with blood. So this is the feature of the hepatic outflow obstruction. Now next is if there is a problem with the inflow. So when there is blockage of the inflow, this includes two major pathologies. One is extrahepatic portal vein obstruction, that is EHPVO, when the blockage occurs of the major hepatic vein, or it could be blockage of small portal vein which causes non-cirrhotic portal fibrosis. So this is very important from the Indian perspective, because this is one disease which has originated from our country, and which is diagnosed by Dr. Sareen et al., Dr. Nayak et al., and Dr. Ramalinga Swami et al., who identified these patients. And because there is blockage of small portal veins, so what will happen is the blood cannot flow out of the portal vein, and there will be black pressure of the blood. So this will lead to portal hypertension because of the blockage of small portal veins, and because of this portal hypertension, patient will develop splenomegaly, he will develop varices. But if we take a biopsy of this liver, this is not going to show much fibrosis, because it is not because of cirrhosis that the portal vein is obstructed. So if we see a biopsy of the liver cell plate will be architecture will be normal, the hepatocytes will be functioning normally, however the portal tracts will be atrophic. So this is what we are going to see on the biopsy, the liver hepatocytes will be okay, however the small tracts will be atrophic and there is absence of portal vein in most of the tracts, or they could be sclerotic. It is known by different name in different countries, like it is called idiopathic portal hypertension in Japan, or it is also known by hepatoportal sclerosis or idiopathic portal hypertension. In India it is called non-cirrhotic portal fibrosis or non-cirrhotic portal hypertension. So it is an important disease that we see in our patients, and it usually affects young males. The second disease is the EHPVO, that is extrahepatic portal vein obstruction. Now in EHPVO there is blockage of the major portal vein. So once the major portal vein gets blocked, what we see here is there is lot of formation of collaterals around the portal vein. So that is called portal cavernoma formation. So if we see radiology, these patients will have a classical portal cavernoma because there is formation of lot of collaterals around the portal vein. So this is called extrahepatic portal vein obstruction. Now in this again extrahepatic portal vein obstruction, the damage to the liver cells is less, so the liver architecture will not be much disturbed and it will be relatively okay. So that is called extrahepatic portal vein obstruction. So that is all about the pathologies of the liver. So it could be a biliary cholestatic as we mentioned. Thank you very much.